Successful rigid gas permeable lens fitting demands careful patient selection, understanding of lens design principles, and knowledge of available materials. All these factors are important when selecting the appropriate diagnostic lens for the patient. This program features 6 routine and difficult to fit patients. Various lens designs and lens to cornea fitting relationships will be evaluated utilizing high-resolution video biomicroscopy. The cases are low astigmatic myope, low astigmatic hyperope, against the rule astigmat, high with the rule astigmat, irregular cornea, and the presbyope. The first case involves a low astigmatic myope with a half diopter of with the rule corneal astigmatism. The following series of lenses show how base curve radius changes affect the lens to cornea fitting relationship. Our first lens is fit a half diopter steeper than K. After the blink, it tends to decenter inferiorly. The upper lid has minimal influence on lens position. This interpalpebral and slightly inferior position is typical of a steep fit on a myopic eye. The excessive lens lag observed would likely cause flare in dim illumination. Fluorescein evaluation reveals central clearance or pooling with 360 degrees of mid-peripheral bearing. This bearing or seal-off could result in trapped debris under the lens along with secondary corneal staining. Excessive edge lift is noticeable from the dense band of peripheral fluorescein. Now, fitting a half diopter flatter than K, the lens is picked up with the blink and drops to a slightly superior, though well-centered position. Lens lag is about 2 millimeters, an ideal amount for an RGP. This is an optimal fit and representative of a slightly flat base curve on a myopic patient. With fluorescein, an on-K alignment fit is observed with the pattern presenting as diffuse and uniform. Though the base curve radius is flatter than K, the typical flat pattern isn't observed for the following reasons. There's a slightly superior fitting relationship. The corneal topography is not accurately predicted within the small area measured by keratometry, and the lens diameter is larger than average. This segment compares high and low edge clearance. Edge clearance, or lift, is the distance between the lens edge and the corneal surface. With this lens design, the dense circular band of fluorescein indicates excessive edge clearance. Inferiorly, it is difficult to observe the junction between the peripheral and secondary curve radii. The high edge lift is confirmed by the presence of bubbles under the lens edge and by excessive lens movement. A high edge lift design potentially interferes with normal blinking and can funnel excessive tears underneath the lens. This can lead to lens edge awareness and 3 and 9 o'clock staining. With this lens, notice the peripheral fluorescein band is narrower than the previous example. To decrease edge lift, this design features a steeper peripheral curve and a narrower curve width. The lens position slightly superior, though still presents a good lens to cornea fitting relationship. The amount of edge clearance is optimum for tear exchange without compromising blink quality. This ensures good debris removal and oxygen delivery. The risk of lens seal-off and adherence is minimized. Use of fluorescein dye is very helpful for clinically evaluating edge clearance. Our second case is the low astigmatic hyperope. The series of lenses to follow show the effect of changing base curve radius and lenticulation. This lens is fit 0.62 diopters flatter than K. Notice how it is picked up by the upper lid and quickly drops or is bumped to an inferior temporal position. The excessive lens lag after the blink can result in variable vision, lens awareness, and corneal desiccation. Fluorescein evaluation reveals a flat lens to cornea fitting relationship characterized by central bearing and excessive mid-peripheral clearance. The pattern becomes more obvious after the lens drops. The bubbles present inferiorly, adjacent to the lens edge, also indicate excessive clearance. Lens movement could result in inferior corneal indentation and staining of the sclera. Now, fitting a half diopter steeper than K, observe the good centration after the blink. Lens lag is about 2 millimeters. There is clearly an improved lens to cornea fitting relationship as compared to the previous flat lens. This improvement may be attributed to the centrational forces of a steeper base curve, along with the greater mass characteristics of a plus power RGP. A steep fitting relationship can be observed with fluorescein. Minimal mid-peripheral bearing and inferior pooling is present. This would be an acceptable fit, although selecting a base curve radius a quarter of a diopter steeper than K could be considered to reduce the bearing area. The following lenses show how a minus lenticular edge design can affect the fitting relationship of a plus power rigid lens. This lens is fit a quarter of a diopter flat on a low astigmatic hyperope. After the blink, it quickly decenters inferiorly. In part, this poor fitting relationship may be attributed to the large mass characteristics of a plus power RGP. The inferior positioning could cause corneal desiccation, symptoms of Flair, and lens awareness. Notice the interaction between the upper lid and the lens edge. A steep fluorescein pattern showing apical clearance is observed, especially evident when the lens positions inferiorly. The small bubbles at the superior lens edge are caused by the excessive edge clearance. This lens is identical to the previous example except for the addition of a minus lenticular edge design. Notice the superior central positioning. The thicker edge allows the upper lid to control lens movement. Viewing with fluorescein, the lenticular junction is clearly observed on the front surface. The pattern is diffuse and uniform, characteristic of an alignment fit. Due to the superior positioning of the lens, edge clearance is greater inferiorly. The use of a minus lenticular has resulted in a much improved lens to cornea fitting relationship. A larger overall diameter may assist in providing a more centered lens position. A minus lenticular edge design is recommended for all plus power and low minus power lenses. This design increases edge thickness, therefore enhances the lifting action of the upper lid. When fitting a low astigmatic hyperopic patient, the use of a steeper than K base curve radius in combination with a minus lenticular edge design will increase the probability of a successful fit. Case number 3 involves the application of rigid lens designs on the against the rule astigmat. Spherical base curve radii will be compared to the aspheric design. Our first lens quickly decenters nasally, then inferior temporally with the blink. The lateral shift is characteristic of a flat or on-K base curve radius on a moderate against the rule astigmat. The lens tends to follow the contour of the steeper horizontal corneal meridian. Fluorescein evaluation reveals a flat lens pattern with bearing centrally along the vertical meridian, along with mid-peripheral clearance and peripheral bearing. This design could cause problems characteristic of an inferior decentering lens, corneal desiccation, symptoms of Flair, and lens awareness. This lens, fit steep, appears to present a better fitting relationship than the previous example. Decentration is not as excessive, however the lateral shift with the blink is still obvious. The lens readily decenters inferior temporally. The against the rule fluorescein pattern reveals vertical bearing and horizontal clearance. Apical touch is especially apparent after the blink, when the lens drops inferiorly. Excessive edge clearance can also be observed. Similar symptoms and clinical signs regarding an inferior decentering lens would apply here. The application of a spherical base curve lens on a moderate or high astigmatic cornea can result in poor alignment and a rocking effect of the posterior lens surface against the tear layer. Our final lens in Case 3 features a progressive aspheric design. Although slight inferior temporal decentration is present, a much improved lens to cornea fitting relationship can be observed. This lens design has a large diameter and a low eccentricity value, or rate of flattening, to better contour the cornea. It provides distance vision correction only. The fluorescein pattern is diffuse and uniform. This alignment fit is attributed to the aspheric design, which exhibits gradual flattening from the center to the periphery of the lens. A moderate amount of against the rule astigmatism presents a challenge in providing a well-centering rigid lens. The application of an aspheric design, as well as a bitoric design in cases of greater astigmatism, will be beneficial options in successfully fitting these patients. Case 4 involves fitting the high-with-the-rule corneal astigmat. The application of spherical versus bitoric lens designs will be presented. It's typical for an Encke lens, fit on a high astigmat, to decenter inferiorly. In this case, the lens positions superior central and presents a seemingly acceptable lens to cornea fitting relationship. However, the absence of an alignment fit is indicated by excessive shifting of the tear layer with the blink. Bubbles observed inferiorly also indicate excessive edge clearance. Fluorescein evaluation confirms a less than ideal fitting relationship. There is superior bearing with excessive inferior edge clearance. At high magnification, the characteristic dumbbell pattern can be observed with vertical clearance and horizontal bearing. An Encke spherical lens fit on a high astigmat may cause subjective lens awareness. There may also be clinical signs of corneal staining and distortion resulting from the lens rocking with the blink. This 1 diopter steeper than K fit appears similar to the previous example. Lens leg is more acceptable. Excessive shifting of the tear layer with the blink is present, and the lens occasionally decenters inferiorly. Bubbles are apparent at the inferior edge, indicating excessive clearance. As with the previous lens, fluorescein evaluation reveals a less than ideal fitting relationship, with perhaps a slightly reduced bearing area. The dumbbell appearance is still quite apparent. The excessive inferior edge clearance due to absence of corneal alignment may eventually result in corneal desiccation. A bitoric lens on the same cornea presents a similar fitting relationship exhibited by the previous spherical lenses. This lens is tucked underneath the upper lid and shows an adequate amount of leg with the blink. There is also periodic bubble formation. With fluorescein, it can be clearly observed that a much more diffuse with-the-rule pattern is present. This design results in an improved lens-to-cornea fitting relationship. In review, a spherical base curve radius lens fit on a high with-the-rule corneal astigmat often results in poor centering and an unacceptable lens-cornea relationship. The use of a back surface or bitoric lens design will provide more of an alignment fit, minimizing the effects of rocking and decentration. Our 5th case pertains to rigid lens fitting on an irregular cornea. 5 different lens designs on a keratoconic patient will be evaluated. We begin our evaluation with a diagnostic lens having both a large optical zone and overall diameter. This lens decenters inferiorly after the blink. Lens leg is at a minimum, which could result in both trap debris and lens adherence. With fluorescein application, a flat-fit bullseye pattern can be observed, a clear indication of poor corneal alignment. Note the heavy central and peripheral bearing along with paracentral pooling. The central corneal staining observed is caused by pressure or bearing exerted by the flat base curve. Selecting a flat base curve radius, if not excessive, can be beneficial for fitting irregular corneas. A flat spherical fit may allow for good visual acuity, comfort, and a favorable fitting relationship, providing the optical zone diameter is not much larger than the apex of the cone. This lens, fit 2 diopters steep, also has a large optical zone and overall diameter. It positions inferiorly with minimal leg with the blink. The corneal irregularity, in combination with a spherical lens fit, encourages the large bubble formation. Adherence-related complications such as trap debris and corneal edema are possible with this design, as well as lens awareness and flare. Fluorescein evaluation highlights the poor fitting relationship. A steep pattern emerges with mid-peripheral and peripheral bearing, creating a seal-off from tear exchange. This design would be unacceptable due to the problems of limited tear flow and the possibility of adherence. Lens decentration in combination with the bubble, which remains in the visual axis, would compromise vision. Fitting a smaller diameter lens with a smaller optical zone appears to provide a better fitting relationship than the larger diameter lenses. There is an absence of both excessive edge lift and bubble formation. The lens still positions slightly inferior, however, and when partial blinking occurs, lens leg is insufficient. A more diffuse fluorescein pattern is present than with the previous examples. The lens centers reasonably well, but peripheral seal-off would possibly limit tear exchange. Selecting a flatter base curve radius would be helpful in providing a three-point touch fitting relationship. This would apply slight pressure to the cone apex and very likely improve the patient's visual acuity. In addition, flattening the peripheral curve radii should reduce the seal-off present in that region. Our next lens is a high eccentricity aspheric design. The good centration is characteristic of most aspheric designs fit on irregular corneas. Bubbles are present along the inferior lens edge, but they aren't as numerous as with the previous examples. As the lens moves superiorly with the blink, excessive edge lift is observed inferiorly. Fluorescein pattern evaluation reveals a flat lens to cornea fitting relationship with excessive central bearing. The inferior pooling is characteristic of a flat base curve on an irregular cornea. The high eccentricity lens design would require a steep base curve radius for paracentral and mid-peripheral alignment. Lens number 5 is the Saturn II lens with a rigid gas permeable styrene-based center and a 25% water content skirt. Centration is excellent. Lens leg is minimal with the blink. The junction between the rigid and soft materials can be easily observed under high magnification. In summary, there are several lens designs that can be beneficial in fitting an irregular cornea. These include the use of a small optical zone, an aspheric design, and a Saturn II lens. Our sixth and final case is the presbyopic rigid lens patient with low width rule astigmatism. The first series of lenses will show the effect of base curve radius changes on the fit of a prism ballasted alternating design bifocal. This lens, fit steeper than K, positions inferiorly after the blink. At first glance, the movement appears desirable, as the distance zone would be positioned in front of the pupil when the patient views at distance. However, the inferior near zone is lifted too far superiorly with the blink and also moves in front of the pupil. This may result in fluctuating distance vision. The steep fitting relationship is confirmed with fluorescein, showing central clearance in mid-peripheral bearing. The lifting of the near zone into the pupillary region is easily observable under high magnification. Selection of a flatter base curve radius may both minimize the interaction of the upper lid and improve the lens to cornea fitting relationship. This half-diopter flat lens positions better than the previous example. It moves superiorly after the blink, but the segment isn't pulled up into the pupil as much as with the steep lens. With fluorescein, a flat pattern with central and inferior temporal bearing can be observed. This pattern is marginally acceptable. Although the use of a flat base curve radius presents an improved fitting relationship, it is not optimum. The lens drops too far inferiorly, and the near zone is periodically picked up into the pupillary region. Increasing prism ballast may be of benefit in this case. Our final section compares alternating and diffractive rigid bifocal lens designs on a presbyopic patient. This alternating bifocal lens exhibits a flat-fitting relationship as recommended for proper positioning of the segment and the distance zone. Observe the lower limbal area. Ideally, the truncation should be approximately aligned with the lower lid. A patient with a lid positioned well below the limbus, as in this case, may experience difficulty in achieving this alignment. It's always important to observe the lower lid position in relation to the cornea when fitting a truncated prism ballasted bifocal design. The distances from the lower pupil margin to the center of the pupil should be carefully measured to accurately determine the segment height. A rigid diffraction bifocal is observed here. This lens offers advantages of pupil independence and ease of fit, as both prism and truncation are unnecessary with this design. To minimize symptoms of glare, it must center well. Patients generally need a higher amount of illumination present when performing near work. Fluorescein evaluation reveals a steep pattern with mild mid-peripheral bearing. This steep fitting relationship is desirable to provide good centration. The central diffraction area is 5 millimeters wide. Individual diffraction zones are more easily seen under high magnification. When this lens becomes available, it should be a viable option whenever use of an alternating design is not possible. In summary, when fitting a presbyopic patient with rigid lenses, it's important to perform a comprehensive pre-fitting assessment. Select a slightly flat base curve radius when fitting a prism ballasted truncated design. Consider a diffractive design when use of an alternating lens is not feasible. These 6 routine and difficult to fit cases highlight the individual variation in corneal topography seen from patient to patient. From these examples, it is hoped that the importance of diagnostic fitting and fluorescein pattern evaluation is understood. They are the essential keys to successful fitting and management of rigid gas permeable contact lens patients.